Next up is Dr. Anjali Bhatt, Madam. She is MD in Medicine from Mahatma Gandhi Institute of Medical Sciences, Varda. She stood second in the university. She has been trained in the prestigious Department of Endocrinology at CMC Vellore. She is very passionate about patient care, research, teaching, forming curricula for various courses and community-based activities. Ma'am has contributed many publications in journals as well as books and invited for talks in many conferences. Ma'am is passionate about watercolor paintings, writing, reading, traveling, music, and motherhood. With this, I invite Ma'am to present Beyond the Frontiers of Glucocentric Approach with Oral Semaglutide.
Thank you so much, Dr. Indumati, and thank you so much, Dr. Vaishali ma'am, to invite me for this prestigious meeting of Synapse. Can I have the right to share the slide? Yeah, I think, is the slide visible?
Yes, sir.
Right, it's seen in the PowerPoint mode, right?
Yes.
Can the technical team say go? Shall I start?
Yes, sir. Doctor.
Yeah, thank you. Thank you so much. So we had lucidly heard from Erende sir just in the previous talk that we need to go beyond the glucocentric approach for management of diabetes and think weight as one of the most important parameter that we track when we treat our patients rather than just being glucocentric. And after having heard the lucid pathophysiology that sir explained very well in the previous talk, let's come to the practical application of this wonderful molecule that is oral semaglutide in management of our obese type 2 diabetic patients. So this is the disclosure. We know that Novo has supported this. The agenda is today about talking about oral semaglutide. In short, the evidence behind use of oral semaglutide in patients who are overweight and with type 2 diabetes mellitus, how their quality of life is better with GLP-1 receptor agonists, and the benefit of early initiation of oral semaglutide in these patients. So coming to the first, we know that oral GLP-1s have been path-breaking in providing very good HbA1c reduction along with body weight reduction, very low hypoglycemia risk and cardiovascular benefits. They are safe in large amount of population, large subtypes of populations. Side effects like nausea or gastrointestinal side effects are transient. And now we have the convenience of having a GLP-1 agonist, receptor agonist in an oral form, which is much more acceptable to our patients rather than the injectable form. So if I have to explain all the evidence that we have about oral semaglutide in one slide, this would be the slide, which is a canvas of Pioneer trials, where Pioneer 1 was conducted in comparison to placebo, Pioneer 2 when it was compared with SGLT2 inhibitors, Pioneer 3 when it was compared to sitagliptin, DPP4 inhibitors, Pioneer 4 versus liraglutide, then we have Pioneer 7 with insulin, not as versus, but as an addition to insulin. And then we have some trials, Pioneer 9 and 10 in Japanese patients. And then we have an ongoing CVOT superiority trial, which results of which will be available in a couple of years, or maybe lesser than that, I'm sure. Then we have special populations studied, the population with renal impairment, and we have a CVOT in Indian subjects in Pioneer 6. So having looked at this, let's see how, as a comprehensive look, oral semaglutide fared well when it comes to HbA1c and weight reduction in patients with type 2 diabetes. So looking at the HbA1c reduction with oral semaglutide, you can see here as a monotherapy, the HbA1c reduction was a whooping 1.5 with 14 mg oral semaglutide, but also 1.3 with 7 mg of oral semaglutide. When compared to empagliflozin, the HbA1c reduction was almost double than that of empagliflozin. We know with sitagliptin, the HbA1c reduction was also statistically significant. It improved the HbA1c even compared to liraglutide, even though it was not statistically significant, but you can numerically see that oral sema was even better than liraglutide in reducing the HbA1c. And what you can see here in the last bar diagram was, in addition to insulin, it reduces HbA1c to 1.2 percentage. Now, we know insulin as one of the most potent hypoglycemic, anti-hyperglycemic agent, where we can reduce n number of HbA1c percentage with oral insulin, injectable insulin. But we do have large number of patients who are on insulin but still are unable to achieve the target HbA1c. And when added to baseline insulin therapy, oral semaglutide can further reduce HbA1c by almost 1.2%, and which is very significant because it, along with the HbA1c reduction, what it is also going to cause is weight loss. So we can see that in patients with HbA1c below 9%, there is a very strong 1.5% reduction in HbA1c with oral semaglutide compared to all the standard of care drugs. Now, as I said, coming to change in the HbA1c, when the HbA1c is more than 9%, the baseline HbA1c more than 9%, you can see that on an average, oral semaglutide reduces HbA1c by more than 2%. So somebody with 7.8, 7.9 is expected to come down to 6 to 6.5, and somebody who is 9.5 or 10 maybe will come down to around 7, and that is the amount of HbA1c reduction that happens with oral semaglutide. So it's a very, very potent anti-hyperglycemic agent, and higher we know that baseline HbA1c, more is going to be the reduction with any drug for that matter. And when it comes to oral semaglutide, the average HbA1c reduction is around 2.6%. So in addition to HbA1c reduction, what we are now looking at as an upstream approach to manage type 2 diabetes, we want agents that can reduce weight. We had agents that can increase weight, then we came down to agents which were neutral, but now we are looking for agents which can cause weight reduction. And if you look at oral semaglutide, 5 kgs is an average weight loss that oral semaglutide can cause. As a monotherapy, you can see that 4.1 kgs with empagliflozin versus empagliflozin, there is 4.7. Even though the difference is not statistically significant, numerically it causes more weight loss than empagliflozin. We can see with compared to sitagliptin. Again, as I said, even though statistical significance was not achieved, numerical significance was oral semaglutide made patients lose more weight than 1.8 mg liraglutide. Of course, there are trials for higher doses, but with what is commonly available in India, liraglutide 1.8, oral sema is found to have larger weight loss. And of course, with insulin therapy, we are worried about weight gain. And when we add oral semaglutide, not only HbA1c goes down, but also the weight is lost. And on an average, 5 kgs weight loss is expected. So in summary, when we use oral semaglutide compared to other oral anti-diabetes agents or in addition to insulin, we can see 1.5% reduction in HbA1c when the baseline HbA1c is less than 9%. In people with HbA1c is higher than 9%, we can expect 2.6% or higher HbA1c reduction, and we can expect 5 kgs weight loss. But I have seen individual to individual, the weight loss is different. I've seen people losing from anything from 5 kgs to 15 kgs weight. And if you continue them on for a longer period of time, I have a patient who is on oral sema for last 9-10 years, and she's constantly losing weight as the time progresses. So the weight loss in 26 weeks, that is the general time for trial, is somewhere around 5 kgs. But if the drug is continued, the weight loss keeps going, keeps progressing in the favorable path. So apart from that, if we look at from the point of view of people achieving the weight targets for oral semaglutide, 1 in 2 patients, that is 50% of patients, achieve a very clinically significant weight loss, which is defined as 5%, 5 to 10% of the current body weight, and 50% of people will achieve 5%, while almost 20% people do achieve more than 10% of their basal body weight loss. Now, is the weight loss in the right way? Are we asking the patient to lose the right amount of weight, or are we making them weak? So GLP-1 receptors, we know, work directly or indirectly by activating the hypothalamus and hindbrain that is involved in appetite regulation. They increase the satiety and remove the cravings for savory or junk food and correct the body weight. So it is happening in physiological way by reducing hunger, energy intake, and food cravings, in addition to acting on the satiety center, which prevents overeating and actually causes alteration in the food preferences. When it comes to body composition, semaglutide reduces fat mass much more compared to the lean muscle mass. Of course, with any loss of weight, there is small decrease in the lean muscle mass also. but the significant amount of fat loss is found when the patients are treated with oral semaglutide. So, of course, when the weight goes down, all the risk factors that are very strongly associated with increase in weight, that is the signs of systemic inflammation, HSCRP, lipid parameters, and systolic blood pressure, waist circumference, also go down hand in hand along with the increase in weight. So, better outcomes when we start initially. We heard Dr. Erende sir in the previous talk that a higher time the patient spends in hyperglycemia, higher is going to be the rate of complication. So the early initiation of such a molecule that will act upstream or act on the basic pathophysiology rather than just acting on glucocentric approach is going to be going to make the patient spend lesser time in the hyperglycemia exposure. The patient is going to have the benefit of prevention of the long-term cardiovascular risk. So higher patient achieve when we start it earlier, the target achieved is higher. 8 of 10 people who had early initiation of semaglutide achieved the target of weight as well as HbA1c. Now, we know the legacy effect, and that is why we want the area under the curve of hyperglycemia in any given patient as early as possible to prevent the longer exposure. Now, it has been studied in a large canvas of pioneer trials and proven to be very safe to use oral semaglutide. The large database is available for around more than 5,000 patients. Even though the most common adverse effect was gastrointestinal, if we think pathophysiologically, even though these are effects that come out of the mechanism of action of the drug, and rather than calling them side effects, we call them as unfavorable effects because they're not exactly side effects. They are the how effect of the mechanism of the drug, and that is how the drug works. So if we explain the patient that this is how the drug works, it is going to cause it is going to act on satiety center and appetite center and make you feel like eating less, or sometimes it can go beyond that feeling and make you feel nauseated. But these are very transient and go away within a few weeks period of time, and after that the patient settles very well to the molecule. So they're very well tolerated apart from the initial gastrointestinal side effects. They are available for convenient use of a large population, including elderly people. There are no special precautions required for them. Hepatic or renal impairment, no dose adjustment is required. In fact, it is now given in patients who are undergoing hemodialysis also. So we don't really have to worry about renal and hepatic impairment. Patients with upper GI tract disease also has been shown to not affect the absorption as well as effectivity of oral semaglutide. So it can be safely given to a large population without worrying much about the organ impairment. Now, it's very important to take the oral semaglutide in a very proper fashion. First of all, we know that a patient is paying out of pocket for a huge amount for this molecule. Even though the effects are tremendous, we may lose the effects if the drug is not taken properly. That is why the instructions are to be given very precisely to the patient that the tablet has to be taken on empty stomach first thing after getting up in the morning with 120 ml of water, not very large amount of water or not lesser than 120 ml. Somewhere around 120 ml of water is required to be consumed along with the tablet. And after taking the tablet, the patient should not go back and sleep, because we have patients who get up in the morning, take the tablet and go back to sleep. So it's important that the patient remains upright after taking the tablet for some time. And these instructions are extremely important. Nothing else should be consumed along with the oral semaglutide, because it's going to hamper the absorption as well as the action of the molecule in the stomach. So remain empty stomach and remain upright for half an hour at least after taking the tablet. So these instructions are extremely important, because we know the innovation of oral semaglutide is in a fashion which is very difficult to have a peptide in a tablet. But this innovation that has happened makes us make sure that the tablet is taken properly and we give the maximum benefit of the innovation to our patient. So coming to the efficacy summary of oral semaglutide, we have seen that patients who have HbA1c of less than 9% have HbA1c reduction of 1.5, but the higher HbA1c persons will have higher reduction of up to 2.5 to 2.6. 5 kgs weight loss is expected on an average, but clinically, all of us have seen that the weight loss can go on and get higher as the patient continues the medicine as the time goes on. And it reduces all the cardiovascular risk factors that are associated with weight, that is systolic blood pressure, lipid parameters like LDL cholesterol, triglycerides, total cholesterol, and waist circumference, along with the fat mass as compared to the lean mass. So this is world's first peptide pill, even though that was not the highlight of the talk, but I think the credit goes to the innovators for developing a pill that can be given, peptide that can be given as a pill. It is very effective option for type 2 diabetes management, strong reduction in HbA1c, also weight loss. It acts through the central nervous system pathway to provide significant and sustained weight loss by working on the satiety center. We have seen that around 5 kgs or even more, and waist circumference loss of 4.7 centimeters or higher is also seen with oral semaglutide. It's easy to titrate, and we don't need to really worry about hepatic renal impairment or age of the patient to provide such a molecule. So those patients who can afford this molecule, I think, should be given the benefit of this molecule, which is the standard of care, which should become a standard of care in patients with obesity and type 2 diabetes. With that, I would again like to thank Dr. Vaishali ma'am for having me here to discuss about this molecule. And if there are any questions, I'll be happy to answer.
Thank you, ma'am. Thank you for the detailed explanation on oral semaglutide. The next speaker is delayed by a few minutes, so we will take the panel discussion with our panel.
Sure.
So the first question is to Dr. Sonali. Sonali, can you throw light on the use of degludec in pregnancy, GDM? Because till now we were not using degludec in pregnancy. So what is the latest data show?
Yes. So the latest data shows that it is safe. Now it is a class B recommendation. So we can definitely use degludec in pregnant women in GDM as well. So we have already started using it and excellent results. So no questions about it.
Okay. Thank you, Sonali. And ma'am, Anjali ma'am, what are the absolute contraindications to oral semaglutide in type 2 diabetes?
So, as such, allergies are considered as absolute contraindication. So if someone who is known to have allergy to any the active as well as non-active components of the drug is an absolute contraindication. It's generally avoided in patients who have a very strong baseline gastrointestinal symptoms. So even though I have seen a couple of patients whom I have explained that the gastrointestinal side effects may be different, and the molecule, the gastrointestinal side effects that come out of the molecule might be very different, but very severe gastrointestinal symptoms at the baseline are contraindications. Of course, we are not trying it in sick patients. We're not trying it in patients who are hospitalized as a molecule to be started or initiated. Absolute contraindication. Type 1 diabetes, right now, we do not think of it as a treatment modality in type 1 diabetes. Right now, we have no clear idea as to whether we can give them in patients who had gastrectomy post-bariatric surgery. We don't know whether that will be useful or not. We need to have data. So right now, we're not giving it for weight loss after gastrectomy of bariatric surgery. Otherwise, I think there are very few contraindications as such for the molecule to be initiated. Then as the time goes, if the patient is developing severe gastrointestinal side effects, we might have to withdraw the drug. But to initiate, there are very few contraindications.
This question is to both of you, ma'am, Dr. Sonali and Dr. Bhatt. Is there any rebound weight gain on discontinuation of the drugs? Because of the cost constraint, some patients do discontinue after a couple of months or 3 months. So the weight loss, is it regained back on discontinuation of the drug? What is your personal...
There is some amount of regain which we have seen, definitely. But although it doesn't go back to where we began with. So thankfully, that is one plus which we can say. But having said that, I think that is why it is extremely important that when I begin dialysis, I always tell them the cost of therapy, explain to them that this is not something which we can start and stop and start and stop and do away with. It's like any other drug which you will have to continue. And if it is not feasible, let us not use it altogether rather than, this on and off effect. I don't know. Dr. Bhatt, what about you?
No, absolutely. When we are accepting a pharmacotherapy for weight loss, there is a very clear scientific thought that the effect will remain as long as you're taking the tablet. So there is no recommendation for discontinuation of the medication when it is accepted for a particular indication. Of course, diabetes is not going to go away, and the epigenetic environment for obesity is also not going to go away. Of course, when you are accepting a drug, the drug's effect will remain as long as you are taking it. But what happens is it's a strong motivator for the patients. When you start the drug, the patient loses weight very fast for initial few time, and that can become a push or a kick kind of a thing for patients to start on a very strong lifestyle modification. And there are patients who, after having the motivation of losing 10-20% of initial body weight, are more motivated to follow a good lifestyle. it I think the coming time will give us more information whether after discontinuation whether patients are able to do. But I feel that patients who are on medications and are seeing that the weight is going down are feeling more motivated to follow the nutritional advices as well as exercise. And some mechanical issues also come when you are extremely overweight. So with losing some amount of weight, you can overcome the mechanical issues and are in a better shape to exercise than when you are extremely overweight.
Yes, ma'am. Thank you, ma'am, for the enlightening points. Another question for both the panelists is any midway between up titration? Is it 3 to 7 straight, or is there any mid doses which we can try between 3 to 7? Because some of the patients don't seem to tolerate 7 well when we up titrate from 3 to 7.
So I have used a strategy where I'm using, if people are not able to tolerate 7 milligram from 3 milligram, what I'm doing is after I ask them to alternate it for 2 days of 3 mg, 1 day of 7 mg. I think that works well with some people, whether there is the nausea doesn't go up to that extent. At the same time, you're maintaining a good level of the drug. At the same time, you're having all the benefits associated with the drug. Over to you, Dr. Bhatt.
I don't think I have much experience on patients who are not able to tolerate 7 mg. Because at such 3 mg, 7 mg are quite small doses. Because I have seen most of my patients tolerating 7, even 14 mg very well. If you do it slowly, take your time, let the patient be very, very comfortable with 3 mg and then initiate 7 mg, that has a higher success rate. Because now they're coming up with 25 mg, 50 mg of oral semaglutide. So I think we should not be worried about unfavorable effects of 3 mg and 7 mg is what I would like to say.
Yeah. Thank you, ma'am. And how to convince the patient, or once we start semaglutide, what are the do's and don'ts for our patients, which we should be counseling about?
Yeah, so like Dr. Bhatt has told us about the technique, that is very important. Very true that patient has to be upright, cannot go back to bed. Many people do that because it's first thing in the morning. So in fact, you can ask them to go around for a walk. That would be still better, because then that waiting period, they are not so anxious about that. I don't have to eat for another half an hour. So that kind of anxiety goes away. I think do's will be mainly that. Yeah, don'ts is that we can't combine it with any other drug. So yes, patients who are taking thyroxine, yes, that has to be monitored well, because then the dose of thyroxine, the bioavailability does go up. So I think some studies have said that taking it at bedtime, late in the night, thyroxine, and taking your oral sema Rybelsus early in the morning does help, because that's what we've seen with our patients. Other than that, nothing more, because the 3 mg is very, very well tolerated, I feel. 7 mg, yes, some people do not tolerate it very well, but I've gone up to 14 also. So I think it is really decently tolerated if started early. I think younger population does very well. So do not hesitate to use it early in the course of the disease. I think it's excellent drug.
Yes, absolutely. I totally agree with Dr. Sonali that the instructions regarding how to take the drugs are very important, because you're popping a pill which is 300 rupees per day it should be given in a very proper fashion, and all the benefits of the drug should be extracted. That's why the patient has to be given those instructions written down, told by you, told by the person who is explaining the drug. Ask the pharmacist to tell the patient to take the drug in that particular way. Bombard the instructions of taking the drug properly. Don't take anything else with the drug. Secondly, I personally feel that I do not ask them to follow a particular nutritional advice along with the initiation of the drug. I often tell them that you be comfortable with the drug first, and then we will start the nutritional changes that are required. Because if you bombard them with both the instructions together, then one side they feel nausea, and other side you have given them a diet chart which says that at 8 o'clock you have to eat this, or at 10 o'clock you have to eat that. That becomes very confusing to patients. So as a personal tip, I would say that I don't give nutritional advice and the drug at the same time. Let them be comfortable with the drug and then start slowly the change in the diet pattern that we want to start.
Thank you, ma'am. And any data, Indian data on use of oral semaglutide in non-diabetic patients? Has it been tried?
No, we'll have to wait for the results. Right now in India, it's
No.
not recommended for non-diabetic obesity.
Yeah, it's not licensed for any non-diabetic use.
Yes.
That's true.
But off record, is it used by any?
No.
Let
Okay.
it be off record.
Yes.
Okay. Okay. Last question, ma'am. Is it only because many clinicians in various forums, when I've spoken about semaglutide, they seem to be of the idea that it should be used only within the first 5 to 10 years of diabetes, early diabetes. They don't feel that when the patient is having an established diabetes of 20 to 25 years, vascular disease, vascular complications. So how do we bust that myth which is in the mind of the clinicians?
No, actually, GLP can be used at any stage of the disease. I strongly believe that. I have used it even with insulin with people who have diabetes since last 20 years, and I've got excellent results. Not only the dose is lowered, the glycemic variability is so superbly affected that you can actually demonstrate it with the CGM to the patient, and it is really mind-blowing. So even with a small dose of 3 milligram also, you're able to set it right. So I think definitely
Does it
that
lead to
needs to be
decrease in doses of insulin, Sonali?
and improve the variability. So
Okay.
with insulin, like we talked about hypos, yeah. So there are a lot of people have hypos. We know that, right? We see that in our practice. So when we are adding Rybelsus to this group of people, so what we've seen is that the variability reduces, the A1C improves, and the hypos are out. So because you're going down, you're reducing the dose of insulin concurrently, and that really helps a lot. Over to you, Dr. Bhatt.
Yes, absolutely. I have a very good experience personally in using this drug with patients on dialysis, because there we are worried about insulin causing weight gain, dialysis, CKD causing water retention, and higher doses of insulin and extremely high glycemic variability. On the day of dialysis, the blood glucose goes down. On the day of non-dialysis, the glucose goes up. So it works wonderfully. And as we know, dialysis is the end spectrum of type 2 diabetes progression. So there is no stage where GLP-1s are actually contraindicated as such. You can use it in any stage. As early as possible is better.
Any lowest limit of EGFR below which we should not use, or we
No,
can use
No,
it?
we can use it in all stages, including dialysis.
Okay. Thank you, ma'am. Thank you for all the inputs by Dr. Sonali and Dr. Bhatt. So I think we will wait for Dr. Hemant Fatale to join us for the next session.
Thank you. Thank you so much,
Thank you,
organizers.
ma'am.
And thank you, Dr. Andu.
Thank you.
Thank you so much
Thank you,
to the
everyone.
speakers. We really appreciate you guys giving your time here. You guys, you're really busy people, but thank you so much for your expertise today, and we appreciate your efforts. Thank you.
Thank you. Thank you, everyone. Thanks.